St. Jude Children's Hospital is actually more well-renowned for our oncology department than we are for our hematology department. But recently there has been a significant change in the thought, at least at our institution, and how sickle cell patients are treated and managed. So as it stands right now, our sickle cell population is treated on campus. They use the same facilities. They have access to the same diagnostic imaging, the same medical resources, and all of the ancillary staff that our oncology patients have. So there are people out there that are fighting for that, and there are places where it is possible to take place.
It's been in and out.
Okay. So I was tasked with the idea of talking about the hope for hydroxyurea. And I'm going to be stuck over here. I have no financial conflicts of interest that relate to the use of hydroxyurea. I do have some funding support from pharmaceutical companies in dealing with other investigational agents. And of course, I'll be talking a lot about the off-label use of hydroxyurea in children. And just as a disclosure, I am pediatric trained. I decided a long time ago that adults are icky, so there's not a whole lot of adult data in this particular presentation. So here's the outline. I thought that I would spend a few slides talking about the underlying pathophysiology of sickle cell disease, and then we'll spend more time talking about hydroxyurea, its clinical impact, and what I think are a couple of topics that at least give me hope for the future. So sickle cell disease is really a disorder of hemoglobin, and all of our hemoglobins have 2 beta globin chains, 2 alpha globin chains, and then they have their heme constituents. And this molecule is what packs and makes up the red blood cells. This is normal hemoglobin. And when you start talking about sickle cell disease and you start you're given the task of hope for the future, I think that in order to have hope for the future, you have to understand where we came from and understand the natural history of the disease in and of itself. And anyone familiar with this story knows that it's a trilogy and we all end up in heaven. So hopefully this will be able to get there. But it's fascinating to me even now that sickle cell disease is really a single nucleotide substitution. It is one mutation that affects so much stuff. It's glutamic acid to valine on the beta globin chain. There are about 2 million people in the United States that have this mutation and at least sickle cell trait. Thankfully, there's not that many that have disease. But in order to have disease, you have to have either compound homozygosity or another condition with another aberrant beta globin chain that allows the %S or the % sickle hemoglobin to be in a high enough percentage to cause problems. There are quite a few people, at least in the United States, that have sickle cell disease, and it's estimated to be about 90,000. Fortunately or unfortunately for me, this is broken down. This is the entire country, and then this is broken down by kind of subsets of the population. And in the South, we have a very high percentage of children with sickle cell disease. As we were talking with somebody earlier today, my particular program, we care for somewhere between 900,000 kids with sickle cell disease. The University of Mississippi Medical Center has probably 2 times that. The Children's Hospital of Atlanta is probably 2.5 times that or so. So we have a large concentration of sickle cell in the South. So this mutation and this one single amino acid shift, what it does is it allows hemoglobin molecules to stick together and polymerize so that they form very long chains. And they do it when the hemoglobin itself becomes in a deoxygenated state. So when it's in the venous circulation or after an infarct, and you end up with these rods that actually deform the cell themselves and cause the classic sickle cell shape. Well, what happens with that is that, you know, when you start deforming cells over and over again, they become quite rigid. And they also, it messes with their cellular membrane, so they become sticky. It's hard for them to squeeze and get to where they need to get to. All the squeezing, shape changes means that they don't live as long, so there's chronic hemolysis. And then all of the constituents of the red blood cell get dumped out into the bloodstream. Hemoglobin's not supposed to be free floating around. It actually causes damage through other pathways. And you end up with this chronic kind of vicious cycle. And it usually culminates in vasoocclusion and ischemia. And this is, for the life of me, I can't think of this gentleman's name. This is an artist who has sickle cell disease, and that's his representation of what pain feels like to him, which is a pretty dramatic picture, I think. So clinically, as we heard this morning, children with sickle cell disease have chronic anemia. They can have acute exacerbations of that, either through sequestration or not making enough red blood cells. And then they tend to have vasoocclusion, ischemia, which can lead to acute pain, stroke, acute chest syndrome, and it, over the long term, leads to chronic organ damage. And the bottom line is that this is a single amino acid substitution. It affects the hemoglobin, but it really affects every organ of the body. You can have complications, pick an organ, and with sickle cell disease, you can have problems with it. And as a pediatric hematologist, the fascinating thing for me is that a lot of this is due to a problem with the adult beta globin, right? So as was discussed this morning, infants when they're first born don't have very many problems with sickle cell disease because at the time of birth, they're still making this gamma globin chain, which is what is made fetal hemoglobin. As you get older, you slowly switch over into beta globin production from the adult marrow. And if you look at children who have sickle cell disease, this is without any hydroxyurea, and it's just what happens normally. Their fetal hemoglobin levels drop pretty dramatically over the first couple of years, but really don't reach their nadir until about 5 years of age. So keeping that in mind, if you look at when children start having complications of sickle cell disease, it's during the times that those fetal hemoglobin actually starts dropping. So you start picking up the first cases of pain, the first cases of acute chest within a year or so of life. But more importantly, at least for us, is that you start having organ damage also very early on in life. So if you look at splenic function, so this is the pictorial diagram of a liver spleen scan. So you inject dye or a particular radiocontrast, and then you can pick up whether or not the liver picks it up and the spleen picks it up. In children with sickle cell disease, 90% of them will have lost splenic function, which is shown by the absence of uptake by 2 years of age, which is important because the spleen is a very powerful ally for your immune system, and it's one of the reasons that children are at increased risk of having pneumococcal sepsis. So this is actually the exact same data that was shown to us this morning, but what I'd like to illustrate with it is that the idea that you have clinical complications that increase with age, especially for pain and acute chest syndrome. So a long time ago, what people realized about this and some of the things that they took away from this is that maybe fetal hemoglobin was protective. We don't see the problems or the complications until the fetal hemoglobin levels drop. So, like John Wayne, maybe tomorrow's hope, we learn from something from yesterday. An example of this is a condition called hereditary persistence of fetal hemoglobin. Now, this is another type of mutation where your body continues to make baby hemoglobin long into your adult years. So if you look at, for example, these are children from the CSSCD, the average fetal hemoglobin was about 8.5%. People who have hemoglobin S, hereditary persistence of fetal hemoglobin, will have somewhere around 40 or 40.5%. And the interesting thing about these kids is that they still have hemoglobin S, but they have a whole lot of fetal hemoglobin. And if you look at their laboratory parameters, they have essentially normal hemoglobin levels. They don't have high reticulocyte counts. And clinically, they essentially have few, if any, symptoms whatsoever of sickle cell disease. So it got people thinking, well, maybe fetal hemoglobin is good for you. And it turns out that in kids with higher fetal hemoglobins, so on this axis, it is your chance of having acute chest versus your percent fetal hemoglobin. And each one of these lines represents a different age demographic. But the take-home message is that whatever your fetal hemoglobin level is, your chance of having acute chest syndrome is much less if you have a higher fetal hemoglobin. And this is just a chest x-rays of a child that we had just recently with acute chest syndrome. This child was not on hydroxyurea. They are now. But this is the progression of acute chest syndrome over 12 hours. So the kid came into clinic, was febrile, had some crackles, didn't necessarily look all that sick. I got called later that evening because they were intubating them before I could get into the hospital while the blood was infusing. We were switching the child over to an oscillator. And so acute chest is one of the main killers in sickle cell disease, and it still is very impressive to me how quickly they can deteriorate. So one of the other complications is dactylitis, which was talked about today. It's the hand-foot syndrome. And this is another graph looking at age with high fetal hemoglobins having less occurrence of hand-foot syndrome. And really it goes for almost any complication that you can think of in children, whether it be dactylitis, acute splenic sequestration, and even death in this cohort, where if you have a higher fetal hemoglobin, you're in a much better place. So we must accept finite disappointment, but never lose infinite hope. So the hope for this is that we can take the information about high fetal hemoglobins being protective, being beneficial, and potentially use that to our advantage. So I actually stole this slide from my previous chair, Russell Ware, who is a huge proponent of hydroxyurea. And he always gave a talk about this, and he said that the ideal medical therapy, it has to work, it must be efficacious, it must be effective, and it must be safe. And for hydroxyurea, at least, the laboratory benefits are you get higher fetal hemoglobins, it reduces your white blood cell count, decreases hemolysis, and it decreases the adhesive properties of the red cells themselves. And it works for acute and some would argue for chronic events. And it works across all age groups. So the hydroxyurea literature really started in adults, and the trend over the past several years has been to give it to younger and younger and younger and younger kids. And I'll show you some numbers about some really young kids here in just a few minutes. But it also has to be effective, and by effective, he always said that, it has to be easy. Just because it works, you have to be able to convince somebody to be able to take it. So one drug, once daily dosing, It has to sustain its effect over years. Very minimal side effects with a wide therapeutic index, which just means that safe in dosing changes. And then no long or short-term, or no long-term risks with good long-term follow-up studies. So I really have been describing hydroxyurea for the last couple slides. It's true that it was originally used as an antineoplastic agent and was just more recently used as an anti-sickling agent in the 1980s, but it's at a much lower dose than what this indication is for. It has multiple mechanisms of action, and the most prominent one is fetal hemoglobin induction. However, I have yet to hear a wonderful response as to why that is. Everybody likes to say stress erythropoiesis, but no one has delineated exactly how it increases fetal hemoglobin. So this is what happens when you give hydroxyurea. This is several cohorts, the bottom one being adult, with the average age being 6, 7, 8, 1.5 or so. And this is something called fixed dosing. So this is where everybody got about the same dose of about 20 milligrams per kilogram. They were treated somewhere between 5 and 8, or half a year to 8 years. And essentially what you see when you do this is a very similar effect to what happens if you give hydroxyurea to adults. Their MCV, or how big the cells are, goes up because it's getting packed with fetal hemoglobin, and your mean hemoglobin also increases. So if a little bit is good for you, then what about a whole lot? So some centers will do something that's called maximal tolerated dosages. And what maximal tolerated dosage or optimal tolerated dosage or the best clinical dosage or whatever acronym you want to use is essentially you increase the dose based on either a reduction of clinical symptoms or to a goal level of myelosuppression, where you're actually looking at the total white blood cell count. And you keep going up on the dose to try to get a maximum amount of fetal hemoglobin production. And in these studies, the top one being adults, the rest of them being in children, they all show a very similar trend that if you do increase the dose, you do get a better dose response. And the conclusion basically is that, again, escalation to the maximal dosage, you end up on average to have a hemoglobin greater than 9, an MCV greater than 100, and a fetal hemoglobin of around 20%. Whereas if you use fixed dosing, the hemoglobin is usually less than 9, the MCV is usually less than 100, and fetal hemoglobin is about 15%. So this led to what in pediatric hematology was a pretty landmark trial. So this was the Baby Hug trial, and it was a very large effort with multiple centers throughout the country. And what they did was they took very young children, 9 to 18 months, and they randomized them to receive either fixed dose of hydroxyurea versus placebo. And what they wanted to see was whether or not giving a child hydroxyurea could prevent them from having end organ damage. And especially what they wanted to look at was the spleen and the kidneys. And then all the secondary endpoints were, was it safe? Did they have any problems? Did they have reduction in pain? Did they have reduction in hospitalizations? One of the novel things about this is that historically, like we were saying this morning, is that we only offered hydroxyurea to people that were sick. So you had to have 2 or 3 episodes of pain, you had to have acute chest syndrome, you had to have dactylitis or something. You could enroll or be eligible for this trial just for being a child and just for having sickle cell disease. You did not have to have any pain. So they randomized almost 200 kids was 193. 192 of them initiated therapy. And then 95 of them got hydroxyurea, 97 of them got placebos, and then they treated them for 24 months. So I didn't actually put a slide in here about the primary endpoints. What they unfortunately found is that giving a child fixed dose hydroxyurea, they could not show that they could protect against organ damage. There's lots, and it's a full discussion about whether or not that's real, whether or not they picked the right endpoints, and whether or not they could potentially do that with dose escalation. But what they did find, one, is that hydroxyurea was very safe. There were some incidences where the white counts dropped, but none of those white counts, dropping white counts, were associated with any forms of serious or invasive infections. And they got what they considered to be good laboratory responses. But the really good part is that children who got hydroxyurea had less pain, they had less dactylitis, they had less acute chest syndromes, and they had less hospitalizations. They also had, this is a graph looking at acute chest syndrome is here, pain is here, dactylitis events, and the need for transfusions. And this is the time on this axis and the cumulative incidence on this axis. So for this particular graph, it's time until the first episode of acute chest syndrome, time to the first episode of pain. And if you look at whether or not it's the first episode, or if you look at whether or not it's cumulative episodes, hydroxyurea had a beneficial effect. So clinically, it works well to decrease at least acute complications. But what about mortality? And we touched on this earlier this morning, but this is adult data. And in adults, hydroxyurea does reduce overall event mortality. In kids, it's really hard to get that kind of data, at least in the US. And one of the reasons is because there's not a whole lot of kids with sickle cell disease that actually don't make it into adulthood. At our center, we have 900 to 1,000 kids, and in the last 5 years, we've had one fatality. And that actually was not sickle cell related. So to look at mortality being your end point, it's very difficult to do that here in the US. This is a Brazilian cohort, and Brazil has a lot of sickle cell disease. They take care, this particular paper has well over 1,000 kids in it with no treatment, and 250 with treatment. Because of resource limitations in Brazil, in order to get hydroxyurea, at least during this particular time point, you had to have very clinically severe disease. So this is back to the 3 episodes of pain, a couple episodes of acute chest syndrome, primary stroke is actually a rationale for starting hydroxyurea. And in this very severe phenotype, compared to the people who did not get hydroxyurea, who are not having pain, who are not having recurrent acute chest syndrome, the ones that got started on hydroxyurea still had a lower mortality rate. Hydroxyurea is good for you. So it improves your hematologic parameters, it decreases the acute complications, and we have pretty good data that suggests that it decreases mortality in kids with sickle cell disease. So a strong mind always hopes and always has cause to hope. So where do we take this? Well, there are barriers to hydroxyurea, and we like to whine and complain about them and beat our head up against the wall. And one of the ones that always drives at least me crazy is maximizing adherence and just trying to get people to take the darn medicine. So we worked with our information technology group, who are just crazy smart people. It scares me sometimes. And we came up with a program called Simon, which scheduled instant messaging over a network. So Simon is a web-based application, and it's brilliant. It goes through our medical EMR, and whatever cell phone number they register to their medical record number whenever they come in and go through registration. If they have elected to receive text message reminders, then the system sends that cell phone number a reminder. And you can set it up to do daily, twice daily, 3 times a day, once a week, once a month. You can do a fixed set of weeks and then stop. It's however you want to do it. And what we did to get around HIPAA compliance was we asked the families, it goes through our EMR, but then we asked the families and the patients to come up with their own messages. So this program, it doesn't cost us a penny either. All of these text messages are free because I didn't know this until we got into this. Every cell phone has an email address that's independent to that cell phone that never changes, regardless of what the phone number is. So we just send an email to that email address, and the phone converts it into a text message. So it costs the family whatever the data plan is that they have to receive a text message. It doesn't cost the institution a dime. It can also tell whether or not that text message was received. So if the cell phone's turned off, then it waits into a pending until the cell phone's turned on, and then it dings back that at least it was downloaded. And they can reply back if they want to, and then those replies are logged into the system. So these are some of the fun messages that they all come up with. And this is my favorite. All right. So this program, we enrolled it or rolled it out, and we use it for essentially every population. So leukemia patients taking 6-MP, Lovenox patients taking their twice daily Lovenox, Hydroxyurea, X-Jade. We have a large HIV clinic, so all the retroviral kids are enrolled. And we just kind of did it as a universal thing, and nobody thought, well, let's go back and look at it. So we retrospectively went back and looked at it, and kids that were on hydroxyurea, and we wanted to use laboratory parameters to be able to monitor adherence. So all of these kids are on MTD, and they have been on MTD for a long time without dose escalation. And we wanted them to be receiving text message reminders for at least a year so that we could follow them and see what happened. So there were 55 kids that met criteria. Almost all of them, well, all of them had SS or S beta 0, and they had all started hydroxyurea at about 7.5, and then started receiving text message reminders at around 14. Notice that the age range this isn't a range, it's an interquartile range. So we did have some very small toddlers and infants who were getting text message reminders for penicillin adherence. But those text messages went to a parental caregiver. And then the average MTD, which is what you would see for most pediatric cohorts, is about 27 or so. So what we found is that following them up to the year before we initiated text message reminders, although they're not dramatic differences, on average they had declining fetal hemoglobin levels. They had declining overall hemoglobin levels and drops in their MCV and rises in their absolute reticulocyte count, which put all together probably means that they were a little bit less adherent than they had been before. And it may not be clinically significant to drop from fetal hemoglobin of 12 to 10, but it at least told us that there was a trend. And we actually take quite a bit of pride in our adherence to hydroxyurea. And we've had several publications that says that over 85% of our kids are over 80% compliant by pill counts and by medication possession ratios. So we see them frequently. Every time they come, they get seen by the social worker and the pharmacist and our PT people and the residents and the fellows, and everybody is always talking, take your hydroxyurea, take your hydroxyurea. And it seems to pay off. But we were a little bit disappointed that we could see a sliding trend down. So then the year after Simon, what we found was that their fetal hemoglobins went back up, their MCVs went back up, their retics went back down, and their bilirubin decreased back down, which again suggested to us that the implementation of this text messaging system at least brought them back up to what their baseline was. And then these values actually stayed at where they increased back up to for the year following initiation of therapy. So the other barrier or the question or the opportunity that was alluded to today with hydroxyurea is expanded populations. And we talked about potentially utilization of hydroxyurea in foreign countries and maybe not so industrialized areas, but I like babies. And historically, even at St. Jude, where we considered ourselves to be pretty aggressive with hydroxyurea, we have a consensus criteria that is probably fairly standard for most other institutions. So if you have somebody that has multiple episodes of pain, clinically severe disease, acute chest syndrome, they've got an elevated TCD velocity, but they won't or can't take chronic transfusion therapy, or they have laboratory markers of pretty significant disease, then it's pretty much agreed upon that you can start hydroxyurea and do so with the agreement of your colleagues. What's not agreed upon is the genotypes other than SS or S beta 0, so S beta plus, SC, SE, any of the others. Age less than 12 months, which really sticks in my craw. And then parental request is not enough. So if the child is asymptomatic and not having any complications, then that's not a reason to start, and some of the other criteria. Now, what happens is if you want to start someone that doesn't fall into those criteria, you have to present them to the other hematologists and make your case for why you want to start them. And the good news for me is that over the past couple of years, they've never said no. So in the infant and toddler clinic, which is the population that I take care of, we have seen a fairly nice little trend here for starts of hydroxyurea in children less than 3 years of age, with the gray box here, which is the one that's growing the most rapid, in less than 18 months. And we, in my clinic anyway, will start children as young as 6 months of age. We actually have a little half birthday party before we give them their first dose. So the question became, what happens with these kids and how well do they do? So we went back and looked at the kids that we had initiated, and we wanted really to see the ones that had been treated for a while. So all of these kids have been followed for at least, or most of these kids have been followed for at least 18 months, all of them for a year. And there were 7 that were less than 18 months, and there were 16 that were, 1.5 to 3. One of the interesting things is that the younger cohort tended to be started because the parent asked me about it. And as a general rule in my clinic, you come in for your hemoglobin identification, I make you cry, everybody's very sad, and then we talk about that, sickle cell disease is improving, we expect children will have normal lives, here's how we're going to help you get a normal life to be able to do the things that you want with transplant, with hydroxyurea, and we start talking about therapy very early. So by the time they're 6 months, I've already seen them 2 or 3 times, and many of them are ready to go and want the hydroxyurea right then. I've had families who get mad at me because I won't give it to them on their identification visit. And the older children tended to be started because they had significant disease. And these are families that were, because of other psychosocial issues of not being able to get off work, difficult time making follow-up appointments, maybe not as stable home environment, it was very difficult for them to commit to the type of significant resources or significant time to initiate hydroxyurea. But then unfortunately the child had complications, and when they saw that the child was having complications, were more willing to start. So unlike in Baby Hug, we dose escalated these kids like we did the rest of our patient population. So they would start at 20 milligrams per kilogram, and then we would see them every 6 to 8 weeks, and after, or every 4 to 6 weeks, and then after 8 weeks, we would dose escalate them if there was no toxicities. And after 18 months, they both essentially ended up at about 27, 28 milligrams per kilogram. So they tolerate about the same dosage. Now that caveat being, I like to use an ANC goal of 1,500 to 3,000, which is a little bit lower than some institutions, but at least in my clinic at UT Southwestern and Children's of Atlanta, we have kind of moved into being a little bit more aggressive because we're not so much concerned about neutropenia. So what we found is what you would kind of expect if you look at the entire cohort. So at 18 months, their hemoglobins are higher, their MCVs are higher, their fetal hemoglobins are higher, and then their reticulocyte counts, white counts are much lower. Interestingly, in the older kids, it's a very similar pattern. In the younger kids, the MCV goes up, the white count comes down. But if you notice, fetal hemoglobin is not statistically significant. It's probably because there's only 5 kids at 18 months. The Baby Hug trial where they got fixed dose, which was in this age range, they maintained their fetal hemoglobin from start to finish. They started with about 19 or 20 and they ended with 19 or 20. But you can, if you dose escalate them, get higher fetal hemoglobins. And we have kids that are in our clinic that have fetal hemoglobins of 40+%. The interesting thing is that when you start pharmacologically inducing fetal hemoglobins, you have to remember that this is also the time that the endogenous production is coming down. So this line represents the kids that started at a younger age. And it'll be interesting to see what happens out here. Unfortunately, I suspect that these two lines will converge out here somewhere. And there may not be an increased benefit as far as peak fetal hemoglobin production. It would be great if it was not the case. But I still think that there's value in this area here, which is a nice area of protection, of inducing it at an earlier age. So essentially, for younger children, we saw fetal hemoglobin induction of about 7%. It was about 4% in older kids. And everybody is really concerned about neutropenia. In the babies, we actually had 0. And in the older kids, we did have a couple of episodes of neutropenia that required dose reduction of hydroxyurea, and then we had 2 others that were associated with viral infections. But none of them required hospitalization or was associated with a invasive infection, and they all responded to withholding hydroxyurea. So, at least from starting our itty-bitty babies, we still get a significant increase in fetal hemoglobin after 18 months. It's well tolerated when you look at the incidence of neutropenia, and they get very good fetal hemoglobin response. And this is actually something that we have been working on for the past 6 or 8 months, is to try to do the next iteration of the baby hug trial with the idea of randomizing to fixed dose of 20 per kilo versus dose escalation in very young children with sickle cell disease, to see if we can get fetal hemoglobin improvement, which we think we can. But then the real question, it boils down to, should we be dose escalating? Is there clinical benefit from that? So the hope for hydroxyurea for me is different genotypes. We were talking about it in a small group earlier. We do have probably 25 or 30 or so kids with SC, S beta plus thalassemia, SE, who are on hydroxyurea. They do tend to get clinical benefit and decreased amounts of pain. They're a little bit tricky to monitor because the laboratory changes are slightly different. For me, I'm interested in initiating it in younger patients. There's also a large population in the international community that could potentially benefit. And, you know, what's the optimal dose of hydroxyurea? Is it low dose just to kind of, you know, maybe decrease or even eliminate the clinical complications of pain or acute chest? Or if you increase it to the maximum that the patient can tolerate with high fetal hemoglobins, does that prevent long-term organ damage? And I don't think that we really know the answer to this. There's definitely 2 camps, and I'm not aware of any good data that would answer that. And then we need lots more tools for improved adherence. Assignment is a wonderful thing, but it doesn't work for everyone. There's multiple reasons for poor adherence, and it's just something that you have to try a lot of different tricks and a lot of different reminders to get kids and even adults to take their medicine. So with that, I'll stop and take questions.
What type of delivery systems do you have for the drug?
What kind of delivery systems?
Yeah, but pills or...
Yeah, so we essentially have every milligram dosage for the tablets that's made. So 100, 200s, 400s, 500s, 1000s. And then our suspension is 100 milligrams per ml that our pharmacy reconstitutes for us. So all of our patients use a centralized pharmacy. It's one of the beautiful things about working at St. Jude. There's a lot of them, but I mean, I can ask them to FedEx hydroxyurea suspensions out to families so that they don't have to come to clinic. But they do everything in-house for us.
I work with the adult population. The majority of them are attorneys.
Mm-hmm.
And they get on their phones and they look at side effects and they look at potential hair loss or really something like come up with that, and they don't want to take it. Is there anything written in layman's terms that can help them understand the benefit? Because the things that we tend to pull up about are very research-based and they don't understand that. So us verbalizing those things doesn't seem to get it for a 22-year-old male who just isn't.
Yeah, we actually have pamphlets, there's online tutorials, there's all kinds of stuff. If you email me your information, I'll send you a whole bunch of stuff.
To address that a little bit, one thing I heard somebody say, and I can't remember who, is that the risk of not being on Hydroxyurea is much greater than the risk of being on it. But can you speak, I've inherited some patients who came from other places who are on both transfusions and Hydroxyurea at the same time. And can you speak a little bit about that, or what happens when you're on Hydroxyurea and get transfused?
So we actually don't have any patients right now that are on transfusion and Hydroxyurea, and it's one of those things where if you're using chronic transfusion therapy to suppress your erythroid compartment, then it doesn't make a whole lot of sense that adding Hydroxyurea would be beneficial. So the argument, at least from our group, has been that we've tried to stay away from that. There are people who will argue that you get the anti-inflammatory effect and the decreased white count, but your percent fetal hemoglobin, MCV, and that kind of stuff, it becomes very difficult to track. So we have, per history at least, stayed away from that kind of combination therapy.
I've heard it explained that you can use it just for the effect on the white cells and perhaps what you get out of nitric oxide release with it, but the people who come haven't really had it explained as to why they're on both necessarily. And it's not necessarily, doesn't seem to be out of desperation because they're failing transfusions.
I don't take care of the chronic transfusion kids, but I have a feeling that if they came in and Jane Hankins saw them, she would stop the hydroxyurea.
So we have some like that and have just used, and I kind of inherited them too, but was with sort of a low fixed dose hydroxyurea, not pushing into dose adjusting at all. And for some of these, it was because of stroke patient on transfusion, still having TIA, still having problems. So that was the rationale to maximize anticycling therapy. And part of the idea was that even with chronic transfusions, you still have 30% sick red cells there. And successfully suppressing reticulocytes has been not very easy to do now.
All right.
Does your pharmacy constitute your own Hydroxyurea from tablets?
No, they get a powdered suspension or a bulk powder and then reconstitute it.
This, the Hydroxyurea medication, is that primarily for the SS trait, or can SC trait patients use that and benefit from it as well?
Yeah. So historically, hydroxyurea has mostly been used in SS and S beta 0 patients. We are now starting to be a little bit more liberal with SC patients, especially those that have had significant clinical events. And we have 15, 20 or so SC kids now on hydroxyurea. They're treated a little bit different. They don't tolerate as high of dosing, but at least anecdotally they do see clinical benefit from their hydroxyurea.
And also, you mentioned like one side effect on an adult perspective. What are some of the most common side effects from the medication? Or does it depend on the dose?
So the most common side effect is myelosuppression. So it's what we're looking for. They get low white counts, their hemoglobin can drop a little bit if they're on too high of a dose, and you have to monitor their platelet counts. Other than that, it's really well tolerated. There can be some skin and nail changes with hyperpigmentation of the nails, and there's some reports that it can reduce the amount of sperm that men make, but it's not, that reduction doesn't appear to be to a level that would cause any kind of infertility. And everyone always says that it goes back to the argument of, would you rather have a little bit of low sperm for a long time or high sperm for a shorter period of time, because you may not survive long enough to be able to reproduce. All kinds of questions. 2 minutes, 2 questions.
With the hydroxyurea, how does it prevent, or does it prevent the kidneys in a big way? Let me rephrase it. How does it help the kidneys? Because so many sicklers go on dialysis if they live a little while.
Yeah, they do. So there's really not a whole lot of great evidence to say that hydroxyurea prevents long-term organ damage. There's some for the kidney that says that high fetal hemoglobins and hydroxyurea may preserve the ability of the kidney to concentrate urine, which is one of the first problems that we see in young children. But to say that it's going to prevent adults from going on to dialysis or frank renal failure, I don't think that we can say that because we haven't treated enough kids long enough to be able to look at that data.
Jeremy, the other thing we see too in our hydroxyurea patients who get transfused is they'll be okay for a couple months after the transfusion, but then they'll slip back into their old pattern once the transfusion's worn off, but before the fetal hemoglobin effect can come back in. So do you guys take any extra steps in sort of delaying to pull the transfusion trigger when they come in sick? Maybe let them to try to avoid transfusing them if it's not absolutely necessary?
No, if our main reason to transfuse is acute chest. So if you come in and you get on oxygen, you're getting transfused, and that's how it goes. And we actually have a pretty aggressive perioperative procedure as well. So sedation for more than 30 minutes if your hemoglobin's less than 9, even if you're on hydroxyurea. Our practice is to transfuse them before that procedure, but I haven't noticed any kind of rebound after the transfusion. I'll have to watch for that. All right, thank you very much.